Hi there, my name's Charlotte Rice, and today we will be talking about the pathophysiology of Parkinson's disease. In the next couple of minutes, we're going to learn about the causes of Parkinson's disease from a neurobiological standpoint on the cellular level, and how that then translates into the symptoms we tend to see in people with Parkinson's. So Parkinson's disease is of course a neurodegenerative disease, which means that it is part of our central nervous system, our brain, our neurobiology, and unfortunately symptoms do progress and get worse the longer a person has Parkinson's. It is related to dopamine, especially a lack of dopamine in the brain, and there's also signs of it being present in the rest of the body, not just in the brain, especially in our gastric tract. There's also evidence of Lewy bodies and the reduced dopamine production in our gastric intestinal area as well. But the most important area that we associate with Parkinson's is the reduction of dopamine in the substantia nigra, which is sort of a controller for movement. It doesn't initiate movement, but it tells other parts of our brain, yep, you're allowed to move this much, hold that movement, and that's sort of why we start to see those tremors, the jerky movements, and also the slowness, because our substantia nigra isn't able to regulate these other parts of the brain quite as effectively. So because of this dysregulation, we do start to see the bradykinesia, the slowed movement, the rigidity, tremors, that stereotypical shuffled gait, and the postural instability we associate with Parkinson's. However, there are more symptoms that people with Parkinson's tend to have. It's not uncommon for people with Parkinson's to experience focal changes and blurred vision. We don't really tend to think of the eyes having muscles, but we do, and some of those muscles are used to control sort of our ability to zoom in, zoom out, and get a clear picture. So if our muscles in our eyes are impacted, we're not able to do that as well. Additionally, the dystonia, which is sort of that like stiffness of the arms, the contractions mostly in like the peripheries, where they get that unique sort of positioning of their arms in particular, is quite a common presentation. It's also not uncommon for people with Parkinson's to have abnormal heart rhythms and develop orthostatic hypertension. Due to the changes in muscle movement, people with Parkinson's tend to develop gastroparesis, as their gastrointestinal tract isn't able to do the peristalsis, which is like the movement that sort of causes that gurgling sound you tend to hear, quite as effectively. So their gastric tract is slowed down. Furthermore, the drooling, the nasal drip is also related to reduced muscle function and control. This is also why people get dysphagia, because they're not able to swallow as well. They don't have that same muscle control and dexterity. There is also an aspect of erectile dysfunction that comes into Parkinson's, although that does tend to be more so related to the side effects of the actual medications people take, including the SSRIs and the anti-Parkinson agents. There is, of course, the urinary incontinence and constipation, which can be a multitude of factors, particularly the stiffening of the muscles, the inability to relax properly, as well as an aspect of some of the cognitive functions we'll get into in a second. So being a chronic health condition, as well as a condition based in the brain, we do see a lot of neurological symptoms associated with Parkinson's. However, usually these things go on a lot longer before they get a diagnosis of Parkinson's, because they can be just sort of an independent condition as well as a symptom of Parkinson's. So this includes the brain fog and nightmares, insomnia, fatigue, and REM sleep disorders. People tend to get diagnosed with those several years before they end up with Parkinson's diagnosis, almost as if they're a precursor to Parkinson's himself, though there's not quite enough research prove or disprove that at the moment. Apathy, depression, and anxiety are also symptoms and comorbidities that come with Parkinson's. Partly due to the change in dopamine levels, people aren't able to regulate their emotions as effectively, and partly due to the medications they're on, as well as the general stress, discomfort, pain, and social changes associated with having a chronic health condition that can lead to a lot of those sort of mental health diagnoses coming alongside. And furthermore, due to the change in dopamine levels, the drop in dopamine levels, a lot of people with Parkinson's have similar symptoms as if they had a diagnosis of ADHD, which also reacts to dopamine and is related to low dopamine levels. So this can come into especially the executive dysfunction and impulse control sort of difficulties, and that can really affect a person's life. So ensuring that they have enough dopamine in their body, the body's able to use it effectively, and they can go about their life as normally as they can previous to their diagnosis is really the aim of the medication I'm going to talk to you about. The dopa is a dopamine metabolite, which means once it passes the blood-brain barrier, it breaks down into dopamine, which then in turn reduces the symptoms we see with Parkinson's, such as the kinesthesia, the tremors, postural instability, and so on. It is almost always paired with Cadopa, as it has been shown to increase the efficacy, the serum levels of levodopa, as well as reduce the nausea we see associated with it. Because of how difficult it is for things to pass the blood-brain barrier, the consistent dosing of levodopa is necessary several times a day and at quite high dosages. And this varies depending on the person and the severity of their Parkinson's, so no two people will be on the same dose.